There are more than 100 medications that interact with this blood thinner and change how it works in the body. Some of those interactions increase the risk of a life-threatening bleed. Others reduce the medication's effectiveness enough to allow a stroke. And then there is the food, the supplements, the changes in diet that happen without anyone thinking to mention them. Most patients taking warfarin every day have no idea how many things can change, whether it prevents a stroke or causes a bleed. There is a medication that sits at the intersection of almost everything else a person takes. Every supplement, every over-the-counter painkiller, every antibiotic, every food high in a specific vitamin, all of it touching the same system, all of it capable of shifting the effect of this medication in ways that can be dangerous. That medication is warfarin, sold under the brand name Coumadin. It belongs to a class of medications called anticoagulants, drugs that reduce the blood's ability to form clots. The body forms blood clots through a complex cascade of chemical reactions. Multiple proteins, called clotting factors, work in sequence, each activating the next until a clot forms at the site of an injury. This cascade is essential. Without it, even a minor cut would become a serious bleeding event. But in certain conditions, the clotting system becomes a threat rather than a protection. In atrial fibrillation, a heart beating chaotically, blood pools in the upper chambers and forms clots. Those clots can break free and travel to the brain, causing a stroke. In deep vein thrombosis, a clot forms in the leg and can travel to the lungs, causing a pulmonary embolism. In patients with mechanical heart valves, the artificial materials trigger clot formation that must be continuously suppressed. Warfarin interrupts the clotting cascade by blocking the production of several clotting factors that depend on vitamin K to form. Less vitamin K activity, fewer functional clotting factors, blood that takes longer to form a clot. For someone at risk of stroke from atrial fibrillation, warfarin can prevent the clot that would otherwise travel to the brain. For someone managing a mechanical valve, it can prevent the clot that would otherwise obstruct blood flow. For someone who has already had a pulmonary embolism, it can prevent the next one. It is one of the most important medications in cardiovascular medicine. It has prevented countless strokes. It has saved lives that would otherwise have ended in catastrophic clotting events. But it operates within a narrower margin than almost any other medication in common use. The measure used to track warfarin's effect is called the INR, International Normalized Ratio. It is a standardized measure of how long blood takes to clot relative to a normal sample. The therapeutic range for most people on warfarin is an INR between 2 and 3. Below 2, the blood is clotting too quickly. The protection against stroke is insufficient. The medication is not doing what it was prescribed to do. Above 3, the blood is not clotting quickly enough. A minor injury can produce serious bleeding. Internal bleeding can begin without any obvious injury at all. That window, between 2 and 3, is the target. And it is a window that almost everything a person eats, drinks, or takes alongside warfarin has the potential to push them out of. Vitamin K is the most direct and well-known interaction. Warfarin works by blocking vitamin K's role in clotting factor production. So the amount of vitamin K a person consumes directly affects how much warfarin is needed to maintain the target INR. Foods high in vitamin K include leafy green vegetables, kale, spinach, broccoli, Brussels sprouts, and collard greens. A person who normally eats very little of these foods and then begins eating a green salad every night will push their INR downward. Warfarin becomes less effective. Stroke risk increases. A person who normally eats a significant amount of greens and then stops, perhaps because of illness, travel, or a change in routine, will push their INR upward. Warfarin becomes more potent. Bleeding risk increases. The message is not to avoid these foods. It is to keep them consistent, eating roughly the same amount week to week so the warfarin dose can be calibrated to a stable vitamin K intake. Most patients are told this in general terms. Many follow it imperfectly without realizing the consequences of variation. But vitamin K in food is only one part of the picture. Vitamin K supplements, taken for bone health, can push the INR downward significantly. Fish oil, taken for heart health, can push the INR upward. Ginkgo biloba, St. John's wort, garlic supplements, cranberry juice in large amounts. All of these are documented in the warfarin prescribing information as affecting INR. Most patients taking these supplements have never been told to mention them to the doctor managing their warfarin. Most doctors managing warfarin have never been told which supplements their patients are taking. And then there are the medications: aspirin, ibuprofen, naproxen, NSAID. These do not change the INR directly, but they damage the protective mucus lining of the stomach. In a person already on a blood thinner, this damage removes a critical barrier between stomach acid and the stomach wall. Gastrointestinal bleeding in someone on warfarin can be difficult to control and potentially life-threatening. The combination of warfarin and a daily aspirin, extremely common in older adults managing cardiovascular risk, creates a bleeding risk significantly higher than either medication alone. Yet both are often prescribed by different physicians who may not know about the other prescription. Antibiotics are among the most significant warfarin interactions and among the least anticipated by patients. Many antibiotics kill not only the bacteria causing the infection, but also the beneficial gut bacteria that produce vitamin K in the intestine. This reduction in gut-produced vitamin K increases warfarin's effect, sometimes dramatically. A person who starts a 10-day course of antibiotics for a respiratory infection while continuing their normal warfarin dose and eating normally may find their INR climbing toward dangerous levels before their next scheduled blood test. If that test is weeks away, the elevated INR may not be discovered until a bruise that does not heal, bleeding that does not stop, or something more serious makes itself apparent. Have you ever changed a medication, supplement, or diet while taking warfarin without getting your INR checked? Let us know below. The list of documented warfarin interactions extends far beyond what any patient has been handed at the pharmacy. Antifungal medications, commonly prescribed for nail infections or yeast infections, can dramatically increase warfarin's potency. Certain cholesterol medications, particularly when a statin is started or its dose is changed, affect how warfarin is metabolized in the liver. Thyroid replacement therapy, when the dose is adjusted, changes the rate at which clotting factors are produced, shifting the INR. Anti-seizure medications, certain antidepressants, some heart rhythm medications, some antibiotics prescribed for urinary tract infections. None of this means warfarin is the wrong choice. For atrial fibrillation, for mechanical heart valves, for recurrent clotting, it remains one of the most important anticoagulant options available. What it means is that warfarin requires a level of ongoing coordination between all of a person's healthcare providers and between the patient and all of their providers that does not always happen automatically. And when it does not, the consequences can be sudden and severe. For monitoring, INR testing at regular intervals is essential. Most patients on stable warfarin check their INR every 4 weeks. Any change in diet, medication, or supplement warrants an earlier check rather than waiting for the next scheduled appointment. Many anticoagulation clinics now offer home INR testing devices that allow patients to test themselves and transmit results to their care team. For patients with unstable INRs or frequent medication changes, this level of monitoring can be significantly safer than monthly clinic visits. For diet, consistency is the goal, not restriction. Leafy greens belong in a healthy diet. The key is eating approximately the same amount from week to week, not eliminating vitamin K foods, so the warfarin dose can be set to a stable baseline. For supplements, every supplement being taken should be disclosed to whoever is managing the warfarin. No supplement should be added or stopped without first checking whether it is documented to interact. And the questions worth bringing to every appointment and to every new prescriber. I am on warfarin. Does this new medication interact with it? And should my INR be checked after I start? My diet has changed significantly in the past few weeks. Should we check my INR sooner? I have started a new supplement. Is there a documented interaction I should know about? These are not complicated questions. They are the questions that keep a narrow therapeutic window from becoming a crisis. If this changed how you think about warfarin, subscribe to Med Truths. Every week we read the labels so you know what to ask before something goes wrong. Here is the truth about warfarin. It works by sitting precisely inside a window, narrow enough that almost everything else in a person's life has the potential to push them outside it. The vitamin K in Tuesday salad, the antibiotic prescribed on Thursday, the fish oil added after a podcast last month. None of these feel like medication decisions. All of them are. The interactions are documented, the list is real, and most of it has never been fully communicated to the person whose life depends on staying inside that window. It has always been in the prescribing information. You just needed someone to read it out loud.